Thank you so much. And thanks again for Dr. Kimmel for his help and for joining us today. So in terms of learning objectives today, I wanted to quickly define palliative care and then discuss the role of palliative care in surgical patients, review some of the misconceptions around palliative care and the barriers to implementation, and then introduce local palliative care resources. So palliative care is a term that's used regularly, but it's surrounded by misconceptions. The actual definition, as per the Center to Advance Palliative Care, is that it is a care for people living with a serious illness independent of prognosis, and it focuses on relieving symptoms and stress of that illness. It's unique in that the patient's caregiver or family is included within the unit of care along with the patient. So it seeks to identify and address caregiver needs as well as patient needs. And it's often confused with hospice. The definition of hospice is that it's for patients at the end of life, generally with a life expectancy of less than 6 months, and more focused on in-home and facility-based services for patients who prioritize comfort and dignity as their care goals. And this is just a diagram from Nature Reviews Urology, which shows nicely how hospice is essentially a small part of palliative care in general. In green, it shows that there's a lot of overlap between the two, but palliative care is unique in that it essentially begins at the time of diagnosis, or can begin at the time of diagnosis, and evolves in response to the patient condition, prognosis, and preferences. Briefly, palliative care actually started back in the medieval ages with the term hospice, where at that time it referred to a lodging often run by religious orders, which took care of ill and elderly people. In the 1840s, this changed where first in France, hospice was used as a term for a place of care for terminally ill people, and then it spread across Europe and North America. And it wasn't until the 1960s where modern hospice and palliative care were essentially developed by someone called Cicely Saunders. So Cicely Saunders was born in 1918 in the UK, and she studied politics, philosophy, and economics at Oxford. She then worked as a nurse during the war from 1940 to 1944, and after that as a social worker, where she developed this idea of total pain. Total pain essentially describes the multi-dimensional nature of a patient's pain experience. So it includes physical pain, spiritual pain, social pain, and psychological pain, all of which interconnect to result in total pain. And this actually aligns very well with the 2020 definition of pain, which was an unpleasant sensory and emotional experience associated with, or resembling that associated with, actual or potential tissue damage. And it is clarified that it's a personal experience. So it's influenced by biological, psychological, and social factors. And it's actually learned through life experiences. So it's different than just nociception, and it can't be inferred solely from activity within sensory neurons. An example of this is when a patient is diagnosed with a new serious illness, it essentially interrupts all expectations for the future, which spiritually can cause a loss of hope. This in itself can cause disengagement from the care plan, which can increase physical pain, but it also can cause family and care team members to feel helpless, which results in fewer visits to the patient, and then they feel the sense of abandonment, which can increase disengagement from the care plan. So it's almost a vicious circle where everything interplays. Cicely Saunders believed that all aspects of total pain could actually be addressed by an interdisciplinary team. And so she dreamed of opening a hospice that could do this for patients. Her idea was to open a hospice that had very good nursing as well as medical and spiritual support for dying patients. And this would be combined with research and teaching. However, she was told that as a nurse and as a social worker, there was no way she would ever be able to do this. No one would listen to her. So in 1957, she actually became a physician. And 10 years later, Dr. Saunders opened St. Christopher's Hospice in 1967, which became the first modern hospice. It became and still is a clinical and research center of excellence. So at the time, it had inpatient wards and outpatient clinics, which were novel. They ran clinical trials and researched emotional and psychological reactions to dying and bereavement, and it was a large teaching center. Several years later, a urologic oncologist from Ottawa called Dr. Balfour Mount was busy with his practice at McGill University. He had an animal research lab and was teaching residents there, but he was also involved in his United Church, where he decided to lead a book discussion on this book here, On Death and Dying by Elizabeth Kubler-Ross. And during this book discussion, people were wondering whether the book reflected the situation in Montreal. And so he volunteered to lead a little bit of a study looking at the situation in Montreal. And after doing this, he's quoted here, "It became clear that to die at the Royal Vic was a catastrophe." And the Royal Vic, I would say, was one of the flagship academic hospitals in North America. And so his findings from this first study that he did weren't actually formally published, but there was an unpublished report that he presented to the Medical Advisory Board of the Royal Victoria Hospital in 1973. And the main themes were that there's very poor communication, including often reluctance of physicians to inform patients properly of their diagnosis and prognosis. The patients feel a lot of isolation and abandonment, which correlated well with the studies at the time that showed that physicians visit patients with decreasing frequency the longer the patient is hospitalized. And also that it takes a nurse longer to answer a call bell that's rung by a dying patient than a patient expected to recover. And there was also themes of very poor pain control. After finding this, Dr. Mount decided to dedicate himself further to investigate and attempt to improve the situation in Montreal. So he ran another study called Death and Dying. And this was a series of 638 questionnaires that he gave to patients and healthcare workers at the Royal Victoria Hospital. And he found that patients generally desire complete openness and honesty in discussions, but physicians are again reluctant to be candid. And two examples of this, so these are two of the questionnaire questions. One of them is a patient should be told the nature of their disease. And here, 78% of patients said always, but only 13% of attendings agreed with this. Most of them said usually. And then a hopeless patient or a patient with a hopeless prognosis, it is wise to tell them either the absolute truth, which is what 65% of patients wanted, and only 12% of attendings agreed with this. Most attendings said instead a positive picture within the framework of reality should be given. And they also looked at emotional awareness of healthcare workers. And you can see here that usually or always these healthcare workers have emotional awareness about 20 to 67% of the time, residents 63, attendings 57, so not very good. The thought was that this limited perception is probably because we have a tendency to see ourselves as sensitive individuals and so can fail to recognize insensitivity to the needs of those around us, and also that patients are reluctant to criticize those who care for them, so might not let us know that we're unaware of their emotional needs. And the paper also suggested that much of the poor patient care for dying patients could be due to a misalignment between hospital goals and patient needs. Hospital goals are usually, investigate, diagnose, cure, and prolong life, whereas patient needs for a dying patient are more along the lines of optimizing quality of life. And this can make healthcare workers or the medical staff feel like nothing can be done, which results in anxiety and guilt and can be portrayed as isolation and indifference towards patients. So after establishing how poor care was for dying patients in Montreal, Dr. Mount sought to find help to improve the situation, and he knew of St. Christopher's Hospice that was opened by Dr. Saunders from the book On Death and Dying, and therefore he called her up to ask if he could come visit, and the Ottawa Citizen described the encounter here. So, "I know you," Dame Saunders told him in no uncertain terms. "You want to come over to London with your wife, see a few plays, have a quick run around the hospice, and then go back. Well, I won't have it." She demanded that he leave his wife at home, spend the full week at St. Christopher's, and immerse himself in the work of the place. Dr. Mount, impressed by the impossibly fierce woman, agreed and left for London in 1973 alone. So after Dr. Mount spent some time at St. Christopher's Hospice, he drafted a proposal to the Royal Vic. He essentially concluded that the hospice model would be too expensive in Canada, but instead he suggested a pilot project that included a hospice-like ward. There would also be a consultation team to work with other hospital wards, home care outreach service, and a bereavement follow-up program. And interestingly, this actually marked the entry of the term palliative care into its modern English usage, because he was told that he couldn't use the word hospice because in French it signified the worst of nursing homes. And palliative care instead, or palliative instead, meant to improve the quality of. By 1976, it became clear that this palliative care program was invaluable, and it became permanent. And Dr. Mount actually devoted himself to the field of palliative medicine. So he stated that it was clear to me that as much as I enjoyed surgical oncology, this was what I had to do. It was totally unethical to leave healthcare the way it was. And palliative care spread across the rest of the world. However, recently it's also become clear that it's more than just for dying patients. This is a groundbreaking non-blinded randomized controlled trial looking at early palliative care in patients with metastatic non-small cell lung cancer that was published in the New England Journal of Medicine in 2010. And essentially, they took 151 patients, split them into a standard oncology care group and then an early palliative care group, where the early palliative care group got a palliative care consultation within 3 weeks of their diagnosis and then at least monthly. And these visits focused on physical and psychosocial symptoms, establishing goals of care, and assisting with decision-making as well as coordinating care. The primary outcome that they looked at was quality of life at baseline versus at 12 weeks. So here you can see baseline, and here 12 weeks via several different questionnaires. The main was the trial outcome index, which was essentially a sum of the scores on a lung cancer physical well-being and functional well-being scale. And for the standard care, the trial outcome index decreased, so quality of life got worse within 12 weeks from 55 to 53, whereas for early palliative care, it actually improved from 56 to 59. And these differences, as well as the difference between the two groups, was statistically significant. They also looked at secondary outcomes. These included mood symptoms. So you can see here, depression was measured by HADS-D score, anxiety by HADS-A, and major depressive disorder by the PHQ-9. And in blue, the standard care patients had way more mood symptoms than in red, the early palliative care symptoms. They also looked at or saw that there were fewer hospitalizations in the last month of life, down to 37 from 54%. There's improved documentation of resuscitation preferences and actually a greater median overall survival as well. A second large Toronto-based RCT was published in The Lancet 4 years later in 2014. And this one's interesting because it included patients with stage 4 and stage 3 cancer, as well as patients with GU malignancy, so GU, GI, breast, and gynecological. And again, there was a standard care and early palliative care group, very similar to the last study. And you can see here in the intervention arm, almost 12% of patients had GU malignancies. In the control arm, almost 22% of patients. And as expected, in the intervention, everybody had at least one palliative care visit, whereas 91% of patients in the control group did not receive any palliative care. And then they looked at surveys completed by these patients, so spiritual well-being scales, quality of life, symptom assessments, and then satisfaction with care. And actually, all of these at 4 months after diagnosis favored the early palliative care group over the standard group, except for satisfaction with care, which was also statistically significant at 3 months. This is just a summary of evidence that has since been published. So essentially, this is 13 randomized control trials, which all demonstrated a benefit of early palliative care. Everything underlined in green was a positive result. So you can see there's overwhelmingly positive results for quality of life, symptoms, anxiety, depression, caregiver distress, survival, and cost. And the very impressive thing here is that there were no negative results in any of these studies. However, interestingly, there's a new JAMA RCT that was published in July of this year, looking at palliative care for 236 patients undergoing major abdominal surgery for cancer with the intent to cure or provide durable oncological control. And these are the surgeries that were included. So 37% of both arms were radical cystectomy, so very relevant to our patient population. And they included patients with essentially all stages of disease and looked at quality of life at 90 days. And their findings were that there was no difference in quality of life, days alive at home, caregiver burden, and anxiety or depression. Here, it is important to note that a large proportion of patients, so almost 40%, had either, benign stage 0, stage 1, or stage 2 disease, and slightly more within the usual care group than within the palliative care group. And the other important thing to note is that they looked at quality of life at 90 days. And even in the last study that we just looked at, sometimes these results weren't positive until 4 months after the initiation of palliative care. Otherwise, in terms of evidence for actual urology patients, it's lacking, but there are just a couple of small retrospective and prospective trials. This is one of those, which was a 6-month prospective cohort study that looked at patients undergoing either radical cystectomy or palliative care and radical cystectomy. And they did surveys pre-op at 2 months, 4 months, and 6 months. Interestingly, less than 25% of the patients who received palliative care actually received a new prescription from the palliative care provider. So just in general, having that interdisciplinary team without actually being prescribed anything, there was a benefit where the intervention arm had lower rates of depression and anxiety and fatigue and improved quality of life. But again, if you actually look at the breakdown of the patients included in this study, in terms of patients who had stage 4 disease, this was 43% of intervention patients and only 9% of control patients. So kind of hard to actually compare those two groups. Regardless, following all of these positive studies, ASCO and actually other guidelines as well, such as the EUA and the NCNN, updated their recommendations. So they now recommend early and concurrent palliative care in addition to standard oncological care for patients with advanced cancer. And advanced cancer was defined as having distant mets, late-stage disease, cancer that is life-limiting, and or a prognosis of 6 to 24 months. And ideally, the palliative care be initiated within 8 weeks of diagnosis of advanced cancer. So just to put this into context, for urology patients, these are survival curves for patients who have, advanced cancer by other definitions. And these are just taken from large randomized controlled trials that have been looking at developing new treatments. But for example, the point here is just to look at overall survival. So for patients with metastatic castrate-sensitive prostate cancer at this time, at 24 months, which was part of that ASCO guidelines, around 80% of patients are still alive. This decreases for patients with metastatic castrate-resistant prostate cancer. So in this trial here, the overall survival was about 11 to 15 months. In bladder cancer, patients with muscle invasive disease, 80% approximately are alive at 24 months. But once it's metastatic at 24 months, it's only about 30 to 40% of patients that are still alive. And then for penile cancer with node positive disease and patients who are undergoing neoadjuvant chemotherapy before undergoing an inguinal lymph node dissection, this trial here just showed that it really depends on response to chemo, but at 24 months, if there's progression of disease on neoadjuvant chemo, then the overall survival is very poor. And if there is either standard disease or some response, then at 24 months, approximately 70% of patients are alive. For advanced or metastatic kidney cancer, here the survival at 24 months was again around 70%. And even though there's no real evidence looking directly at the impact of palliative care on different urologic oncology patients, there is significant evidence that shows that there are unmet needs in this patient population. So this is an example of unmet needs in prostate cancer. It was a large systematic review looking at 20 studies that kind of summarized the themes of concern of men with prostate cancer. And the main themes were under emotional support, treatment side effects, and uncertainty/lack of information. In terms of emotional support, patients felt that they needed long-term support for emotional and psychological support from diagnosis all the way to survivorship. And they felt that more time with a specialized cancer nurse to provide practical, emotional, and psychological support would help with this. And they also wished that they had gotten more acknowledgement on their emotional responses in dealing with prostate cancer, as well as on the burden that it was for their caregivers. And they wished that they had been, that they'd received more encouragement for self-care for themselves and their caregivers. Generally, they felt very unprepared for the severity and duration of side effects. Then they said if they got information, it was generally too little, too late, and that having more information would help them realistically appraise or reframe their experiences. And then on the right of the slide, I just put essentially what the key elements of palliative care are. And in blue, I starred what the overlap is from these unmet needs and what is addressed in palliative care visits. So you can see there's a lot of overlap, for example, addressing coping, emotional status, discussing treatments and effective treatments, and engaging family members. The other thing they stated was that their experiences were full of uncertainty and anxiety, largely because they felt that there was a lack of information about treatment options, outcomes, and prognosis. And overall, there was a poor understanding of the link between illness, experience, and process of care. So they didn't really understand when events in care would take place and who would be responsible for that. For example, why would they get a repeat biopsy? When would that happen? Who would do that, etc. And then they felt that communication was limited and difficult, but it was improved if a partner or trusted other and specialized nurse were involved. And again, here is just highlighting kind of where the overlap is with palliative care visits. There's also unmet needs in muscle-invasive bladder cancer. So this is a survey of 30 patients at Mount Sinai Hospital who underwent cystectomy. And it showed that 1/3 of patients preoperatively felt depressed after their diagnosis. They felt that they had insufficient information about self-care after surgery, finances, medical insurance, the healing process, and were very worried about things like survival, pain, change in body image. Postoperatively, 50% of patients had difficulty related to recovery, and this wasn't just physical, but also emotional. And then even during survivorship, which was described or defined as even up to 4 months after surgery, 1/3 had emotional distress, which included depression, worries about the future, difficulty to adjusting to daily life, and sexual dysfunction. And only around 6% of patients actually got help with this. The same is true for testicular and kidney cancers. So 2 separate systematic reviews were done by an Australian group looking at unmet needs coded by several different domains. 5 of them are listed here. So physical, psychological, cognitive, health systems, and social needs. And they found that in 36 studies looking at testicular cancer, and 18 studies looking at kidney cancer, around half had physical needs, and the vast majority of patients had psychological or emotional needs that were not addressed. And even the others here were relatively common. So despite this evidence for palliative care and clear unmet needs in urologic malignancies, the utilization of palliative care remains low. This is just a table that I put together from a bunch of different papers that quote numbers from the National Inpatient Sample Database, and it shows that around 7% of patients with locally advanced penile cancer received a referral to palliative care. Only 17% of metastatic penile cancer, only 10% of metastatic prostate cancer with admission. So patients who were actually admitted, only 10% of them received referrals to palliative care. And then for metastatic bladder cancer, the numbers improved significantly from 2.5% in 2003 to 28% in 2014, but this is still a minority of patients. There's a study looking at when palliative care consults are actually placed in patients with bladder cancer. So 294 patients who underwent radical cystectomy. And you can see of the 9% of patients who received a palliative care consult, the majority were for failure to thrive or other symptoms such as severe debilitating pain. And there were no proactive palliative care consultations here. Additionally, there was a large meta-analysis looking at almost 12 million patients from 23 different countries, and they found that the median time from initiation of palliative care to death was only 19 days. So palliative care is not being initiated early on. Interestingly, the rates of palliative care referral are actually worse in surgical services than medical services. And this has been shown in a couple different studies, but one of these is this Veterans Health study looking at 191,000 patients that were admitted and died over a 4-year period. And they found that these patients are 16% less likely to receive palliative care if on a surgical service. And this can't be attributed to poor access because in terms of academic surgical oncologists, 92% have access to palliative care. So there's some thought that it might be partially because the personal identity of a surgeon is often stereotypically a fixer, and therefore there's very high demand for excellence and operative success, and referring to palliative care signals that the surgeon has given up. This was confirmed. Someone confirmed in a 2021 study where 46 surgeons were interviewed to get an understanding of their attitudes towards palliative care. And these are several quotes from that study. But the surgeon said things such as, palliative care, I think, is complicated because families often think they're interchangeable with hospice, and they can potentially get offended if you suggest that we get palliative care involved. So themes of misunderstanding. Here, they're concerned that family members, doctors and nurses think it's giving up, or that it means nothing can be done, that patients have unrealistic expectations and they don't want to talk about palliative care or hospice, or that it just means that the surgeon wants to get rid of the patient and that they're written off. So overall, lots of fear of what the patient may think, misunderstanding of what palliative care actually is. A similar study was done interviewing instead patients and caregivers with bladder cancer. And interestingly here, they specifically asked, does accepting palliative care mean giving up? And 75% of patients disagree. And 66% of patients think that it's the doctor's obligation to inform all patients with cancer about the option of palliative care. But if you actually look at the answers to several survey questions, there is significant discordance where patients say that they don't feel they need it because they're able to take care of themselves, or they don't want to be associated with palliative care because it feels like it means that they're helpless. And so overall, there's still this lack of nuanced understanding that led participants to believe that they did not need or would not benefit from or weren't eligible for palliative care. And so the conclusion of this study was essentially that patients require further counseling on what palliative care is. And there were 2 more studies that again showed this lack of patient awareness. One of them looked at almost 3,500 Americans, of which 70% had never even heard of palliative care. There's another study surveying almost 2,000 Italians where 40% had never heard of palliative care, but only 24% had either a somewhat precise or adequate idea of what palliative care meant. And this is especially concerning because there's been studies that show that there's a very strong correlation between palliative care knowledge and receptivity to care, including a survey of 272 bladder cancer patients and their caregivers, shown here, where across the bottom is palliative care knowledge, and this is receptivity to care. And so, they're definitely correlated. So just to get a better understanding of what palliative care visits actually entail, there was a 2013 study published by Young in JAMA, which they did a qualitative analysis of Temmel's RCT. So that was the one looking at non-small cell lung cancer that we looked at earlier. And they essentially just looked at what the palliative care visits in that study entailed, with the goal to identify what the key elements are, kind of explore the timing of the elements, and then compare palliative care and oncological visit notes. And they found that essentially oncology visits are in the light gray up above, and then palliative care is down below. And palliative care visits were usually individually tailored and complemented the standard oncology visits very well. As you can see here, for example, palliative care focused a lot on addressing coping, which wasn't focused on at all in oncology visits. They also engaged family members and spent time building rapport and relationships, whereas in oncology visits, there was more time expected spent on discussing cancer treatment, as well as assessing and managing complications of cancer treatment. And so, again, they found that initial visits were generally time intensive. There was time spent building rapport with patients and families and establishing illness understanding and discussing symptoms. But then later on, the discussion changed a little bit to talking about cancer treatments, end-of-life issues, and again, symptom management, patient and family coping, and illness understanding. What's frightening here is that it seems like there's severe workforce limitations in palliative care. So this study looked at, in 2010 in the USA, there was an estimated shortage of 18,000 palliative care physicians. And then they looked at essentially predicted patients eligible in the light gray and predicted physician workforce in the dark gray. And by 2030, there's an expected 20% growth in patients eligible, but only 1% growth in palliative care physicians. So taking this into consideration, the ASCO guidelines actually recommend that all physicians receive education in primary palliative care skills and administration of palliative care, so that not every single patient is referred to palliative care. And so they put together this study essentially demonstrating on how palliative care can be implemented. They use what's called the TEAM approach, which stands for time, education, assessment, and management. So time referred to 1 hour every month should be spent on palliative care with these patients. It doesn't have to be the physician, it can be a nurse as well. The education should be done via recurrent discussions about prognosis, symptom management, etc. And they have this nice table that has a list of topics available about what should actually be discussed with these patients. Assessment, so there should be formal symptom, spirituality, and psychosocial evaluation tools used, and formal goal setting done. And then for management, they recommended that interdisciplinary teams be used. So there's different models on who should actually manage what, but essentially the consensus is that there should be an attempt of either the oncology or surgery or primary care physician to address basic management of pain and symptoms, as well as depression and anxiety. There should always be an honest discussion about prognosis and goals of care. And then for example, in this diagram here, they suggest that when a patient is relatively straightforward, these basic things should be delivered by the oncology team, but palliative care team is available for advice and help. And then as patients get more complex, these mesh a little bit more, and palliative care takes over managing the patient a little bit more. And then also, in order to avoid overwhelming palliative care physicians, it's been suggested that patients are referred to palliative care, a consultation is done, and then they're referred back to primary care, who manages according to the recommended plan until things become more complex, and then they're referred back. So it's a little bit of a back and forth combined management. There's very good local resources for us that we can use that are very easily accessible just through the BC Cancer website. So these are just screenshots taken from that website, but there's a pain and symptom management / palliative care clinic that you can find through BC Cancer with very easy referrals. It's similar to when we refer a patient to MedOnc or RadOnc, but you essentially just download the referral form and can send that in. And then on the same page, there is also a nice patient information brochure that can provide some education to the patient around what it means to be referred to palliative care. There's also a nice phone helpline that they say is staffed 24/7. If anybody needs assistance delivering palliative care, it's always a good resource. And then finally, I found that BC Cancer itself is a good research that could be used for patients. So actually, when you go on the BC Cancer website, this helpful little pop-up comes up on the side, and you can click on supportive care, or your patient can click on supportive care, and then it comes up with all of these options that, if they're followed, it can lead you, for example, to this emotional support page where you can find support programs. There's a bunch of helpful handouts on the side, and then specific links to other helpful pages. The patients can go onto this patient and family counseling page, and here it describes what is offered from BC Cancer in terms of counseling. And it's interesting, patients can just refer themselves. So everything is covered and they do not need a formal referral. So very good resource to make patients aware of, with phone numbers that they can call. And then finally, there's also a psychiatry services available. For this, they do need a formal referral, but still, I think that having this information for them is useful. In that they can then ask for a referral if they believe that it is something that would be beneficial to them. So in conclusion, we discussed that palliative care is a specialized medical care focused on relieving the symptoms and stress of a serious illness independent of prognosis. Early palliative care results in improved quality of life, symptoms, anxiety, depression, and decreased caregiver distress, as shown by multiple large studies. Guidelines recommend that referral for all patients with advanced cancer be done within 8 weeks. And as per the ASCO guidelines, this includes any patient with metastatic late-stage disease, life-limiting, or with a prognosis of 6 to 24 months. And even though a lot of this research isn't directly in urologic oncology patients, we have seen that there are significant unmet needs in this patient population. So it is very important that we address symptoms, side effects, and emotional distress in our patients. And this can be done through referral and also through giving patient resources such as the BC Cancer webpage. Any questions or comments?